Thanks for this kind introduction, Makis. We are on the road to Maastricht, and I will present a teaser on our venous leg ulcer workshop, giving some ultrasound techniques and tactics. A comprehensive venous insufficiency examination involves, first, clinical evaluation, anatomical study, and third, the venous valvular hemodynamics. So everything with only one purpose, that is early intervention. This picture was taken by me when I was walking through a photo gallery, and this is what I call a ulcer at first glance. And my first thought, of course, it was compression stockings. Yeah, it's kind of weird. So this is according to Professor Alan Davis, from diagnosis to treatment, we should be able to do it within 2 weeks. We can certainly do it with cancer and other diseases, so why shouldn't we be able to do this with leg ulceration? I completely agree with him, and I think it could be even faster than that. Ultrasound is the first line non-invasive test in all patients with venous leg ulcers. It has a high level recommendation. It's very similar to ankle brachial pressure index in ischemic ulcer. So what do we need to see? Not only the source of reflux, but the source of disease, since they are not the same, they're not synonymous. So we look for the superficial venous system, the deep venous system, as you talk here today, and of course the perforators. We try to understand the hemodynamics and the anatomy of this disease. We try to find signs of incompetence or obstructions. So talking about perforators, be careful before blaming them for the venous disease. Perforators with reflux may be pathologic, but not necessarily the source of the disease. They may be the drainage. This is a book that I recommend you all to take a look. I contributed with a chapter about venous anatomy, and it brings a lot of knowledge about this issue. So vein hemodynamics is still controversial. We have limited and contradictory literature, and this is a figure which I try to simplify these types of perforators. First, we have the insufficient ones, when we find an outward flow in systole and diastole. Competent ones, where we find inward flow in systole and no flow in diastole. And the third one that deserves attention because can be tricky, that are the re-entry perforators, when we noticed an outward flow during systole and an inward flow during diastole. So it's considered a bidirectional one. As you all know, ultrasound for the diagnosis of infrainguinal reflux is well established. However, it has not been widely adopted as a tool for diagnosis of deep vein obstruction and incompetence, thrombotic or non-thrombotic. And we developed this worksheet trying to simplify the understanding the venous infradiaphragmatic reservoir, trying to make it simple and during your day in your work. So it's available in this QR code. So the question is, which abnormal veins should be treated and which should be treated first when multiple sites are found to be abnormal? These are the results of a multi-center cohort study where the researchers evaluated 832 patients with venous leg ulcers. And as you can see, superficial and perforator systems were involved in almost half of the sample in this study. Second, we can find the superficial incompetence. And third, the deep superficial and perforators together. So you can conclude that it's a multi-level disease. So in Maastricht, we will be together discussing, learning with each other. We are trying to understand what maneuvers elicit better reflux in different areas. The Valsalva maneuver, distal augmentation, proximal compression. So it's going to be a hands-on and very comprehensive and learning experience. That's because training is of fundamental importance. It's strongly dependent on the skill and experience. I recommend you to take a look in this article who should do diagnostic venous scanning. And of course, it depends of the type of scan required. It can be really easy when we are investigating DVT, for example, but it can be very difficult in patients with post-thrombotic syndrome. So it's tricky sometimes. In conclusion, patients presenting with venous leg ulcers can be quite complex, and I really want to make it simple. Sometimes you just need to know where to look for it and how to look for it. And in search for knowledge, nothing better than a master's advice. So I asked Professor Haag, how can I better understand and study venous hemodynamics to improve the treatments I offer to patients? And his wise answer was, you should perform venous scanning of them whenever possible. So let's do it together in Maastricht. And thanks for your attention.
Thank you very much, Joanna. It was a great and very well-structured presentation. I'm really looking forward to what's coming next in Maastricht. So, of course, I mean, there we can really go much more into detail, and also enjoyed the discussion before already quite a lot. So it's just a very small puzzle piece that we can show today. So in order to see the whole puzzle, you have all to come to Maastricht, of course. Are there any questions, comments?
The only comment I want to make is, ulcer is a complicated issue, and it's, in my opinion, completely a multifactorial disease. It is not just a reflux or obstruction. If you look at the patients carefully, a lot of them have, disorders of their feet, such as flat feet or concave feet, They have, obesity, right? They may have previous infections, right? They have lack of physical activity. So this is many things. More importantly, when we look at the ultrasound, what we find on the ulcer is interesting because it depends on your pattern of referral. If a cosmetic practice, and you see some ulcers with a little bit of, ulcer in the medial malleolus, it's very likely to be an ulcer because of superficial disease. But if you go to university hospitals or major places, then you're going to see the involvement of deep system is much higher, right? So it is not so easy to go in a book or read a paper like the one by Peter Lawrence and say, oh, this is like most superficial disease. Indeed. But the importance of deep venous system, I think in the publications has been often undermined, but it's nobody's fault. It's really a referral pattern.
Absolutely, could not agree more. I think it's really an interdisciplinary thing. So therefore, I'm looking forward to have this interdisciplinary approach. During the EVC, during the workshop on the ulcers. One part of that, of course, will also be the sclerotherapy, which will be a big part. And we have Tobias Hirsch with us, who will also give you some insights of what will happen in Maastricht, and also some insights what role sclerotherapy plays in the approach of leg ulcers.
Thank you, Dirk, for introducing my person, and thank you, Human, for inviting me to Maastricht once again. It's always a pleasure to be there, and an honor as well. And I love to join this workshop, this masterclass about a holistic approach to venous leg ulcer treatment. I think what Nikos told us is one of the most important issues. It's not only a superficial reflux that we have to treat, but this is one issue we can provide to the treatment. Patient education probably is the most important issue, and nutrition and all these issues have to be kept in mind. But what we can do is what we see when the patient presents in our practice. And I think after we have identified the source of the reflux, when a superficial vein disease is the cause of ulcer, we can then continue treating. Compression is one of the most important issues, but sclerotherapy can also be a very valuable part of the treatment. And now I want to share my screen. Well, physicians have been using sclerotherapy to treat varicose veins for centuries. modern sclerotherapy enables us to treat side branches, truncal veins, and also spider veins like this, and venous leg ulcers as well. The procedure is very gentle and has few side effects. It's backed by a lot of evidence, which is contained in the international guidelines, as you can see in the baseline. Only 1 in 10,000 patients is suffering from one of these side branches. This is more gentle than any other varicose vein treatment options, and it's cost effective. You only need a needle and 2 syringes and the sclerosant, and this only a couple of cents, an issue of cents. We can combine sclerotherapy with any other treatment modality. There is a channel in the RFA catheter that enables us to administer the foam, and there are special laser devices that are only compatible for that, and you can feel free to use sclerotherapy also in an when you prefer open surgery. So we can conclude sclerotherapy is the multifunctional tool that fits into every toolbox. And how does sclerotherapy fit to ulcer treatment? We can treat truncal veins. We can treat the perforators that also play a very important role when it comes to ulcer healing. And then we can treat the feeder veins in the ulcer tissue bed. According to the European guidelines, sclerotherapy is suitable for truncal veins with a diameter less than 6 millimeters. And according to the choosing wisely recommendations of the French Society, it's the first-line treatment option for diameters less than 4 millimeters. This is Alan Davies at the Charing Cross 2018, and here he is presenting the EVRA trial, which was a game changer, and which is the first study to provide level 1 evidence for using early endovenous ablation to treat ulcers. The conclusion of this study was that in the early intervention group, ulcers healed faster and also free time was longer. When talking about endovenous procedures, we mean radiofrequency ablation, we talk about glue and laser. One special thing with this EVRA trial is that the majority of the patients were treated only with foam sclerotherapy or had sclerotherapy as an add-on treatment. When one advantage of sclerotherapy is that we can treat both truncal veins and perforators, but also the feeder veins of the ulcer. And this is what we do in our center. It's a very easy 2-step procedure. First, we treat the perforator using a direct puncture or a sheath after we have closed off the truncal vein, if the truncal vein was the source. And it's important to use low volumes of the sclerosant when it comes to perforator treatment, but a high dosage. So we use only 1 or 2 millimeters polydocanol, but 2 to 3%. And once the perforator has been occluded, we can start with the second step, the treatment of the feeder veins and the peri-ulcerous vein network. It's easy to visualize the refluxing feeder vein just by compressing the tissue around the wound, and you can see the color changing. and under ultrasound guidance, a needle is inserted and the microfoam is applied. And for this, we need higher volumes, because this network is not only the thin veins we can see using a vein light. In the depth of the tissue, we can see that it's a big network, and under ultrasound control, you can apply the foam, but we use a low dosage, and have to make a note: polydocanal foam 0.5% is off-label use, but this is how we do in our practice. This British work group published the results of 200 patients and 37 with ulcer who underwent this kind of treatment. And 1 year after foam treatment, more than 90% of the treated ulcers had healed. And the 24-week follow-up date makes it possible to compare the results to the results of the SCAR trial, and their healing rates after ultrasound-guided foam sclerotherapy were even higher than in the surgical arm of SCAR. Similar results in this study: 82% of chronic wounds healed within 3 months. I have prepared 2 cases from my practice. This is a 76-year-old female who presented in my practice with this ulcer. I saw her the first time in 2014, and we did a small saphenous vein treatment using Clarivane. She underwent a stripping before, already in 2009, but this is from 2021, I think. And the source of this also was the Cockett perforator. And we did exactly what I have presented a couple of minutes before. And this is the result after 2 sessions of ultrasound-guided foam sclerotherapy. And here we have another case. This is a case with a GSV disease, reflux up to the down to the ankle. But as you can see, 3 months after radiofrequency ablation, we don't have a complete healing of the ulcer. We see a clear tendency of healing, but this is not healed. And so we continued with the same protocol. And this is after 3 sessions of foam sclerotherapy of the ulcer bed and feeder veins of this ulcer. It's clear that we also used wound dressings and consequent compression therapy for those patients, but as an add-on, we usually also perform sclerotherapy. So let me come to the take-home message, and probably you are already at home, so take it as a message. Sclerotherapy can be a standalone procedure or an add-on in ulcer treatment. Sclerotherapy does not damage the integrity of the skin. This is also very important. Cases of recurrence. We know that other techniques can be superior to sclerotherapy, but sclerotherapy is gentle and very cost-effective, and you can do repeat treatment, and cases of recurrence can be easily dealt with during the follow-up wound treatment sessions. The patients come to your practice because the wound has to be treated, and last but not least is the most cost-effective reflux treatment, and also a cost-effective treatment option for ulcers. When you keep in mind, you have to keep in mind that wound dressings are very, very expensive, and these are the topics we will teach you when you come to Maastricht and join our workshop on the holistic approach to venous leg ulcer treatment. Thank you very much.
Thank you very much, Tobias. Great presentation. And I also like the Swiss knife, of course, and you have been also sharp as a knife, as usual. So I think it's good that we see there's many ways and let's say different parts that need to put together in order to treat an ulcer in the right way. So we also have a question now in the Q&A. It's how about just obliteration creates a venous vein and injunction of perforator GSV ablation more longer to make sure they close? Yeah.
The point is that perforators have always a high rate of recurrence. So we know that the results after sclerotherapy are inferior compared to laser or radiofrequency or SEPs. But this is not an issue in perforators the same way like it is when we talk about truncal veins, because we have a reflux, we have a recurrence rate of around about 50%. And if you use foam or if you use a laser or whatever, and so you have to you have to make clear that repeat sessions are necessary. But the point is, you see those patients again and again because they have ulcers. And on the other hand, we have a recommendation only to treat perforators if they are connected to skin changes or to ulcers. You should not treat perforators only when you treat a C2 venous disease.
Thank you very much, Tobias, for answering these questions. Are there any other comments or questions from the panelist side?
I just would ask Tobias about the complication of direct puncturing of the perforator and sclerosing it. Even you use 2 milliliter of a higher percentage.
Yes. You think of
DVT.
Deep venous DVT?
Yes. Yes, and I am really asking you because I have not much experience. So yes, you are doing it every day.
Yes, yes. It's always a question. The recommendation is not to treat perforators with a direct puncture, but the foam will always run into the deep venous system. This is always the case. You cannot do anything about against that fact. And so we ask the patients to flex the ankle and to move the legs a little bit, not the leg but the foot, as a kind of DVT prophylaxis. But I have never seen a DVT after that type of treatment in my practice. You have to inform your patients about the risk of DVT, but you have to do that always when it comes to sclerotherapy or vein treatment. But I think there is no higher risk to induce DVT. But you should use only small volumes. I think this is important. If you put in 10 milliliters, you have 10 milliliters in the deep venous system. And the point is not that the patients will have DVT after that procedure. The point is that higher volumes will affect other regions. So they will have visual disturbances and all these things that can happen when you use bigger volumes of foam.
Thank you.
All right, so from deep to superficial, we're coming to what's happening around the leg, and we change from Germany. So warm welcome also to Rebecca, and we're looking forward to your presentation. So the stage is yours.
Yeah, thanks for the invitation. I have no disclosures, but I guess this is a little bit, boring about compression and all the recommendations that we have, because this is an important article by Dr. Parch that he has just left the last year. And he was like the master of compression. So I guess this is important to know, the grades of recommendations, because sometimes the patient doesn't want to use any compression stockings. So we have to know that there is a very important part of the treatment of the patient with ulcers. So we have different recommendations. For example, we have recommendations for chronic venous disorders only in healthy individuals. We have recommendations when we have skin changes caused by chronic venous diseases. We have recommendations for preventions of venous leg ulcers recurrence. And we have recommendations to improvement the healing, that it's the important thing of this talk. So we have that they recommend to use the of ulcers kits that we know nowadays. This is the name of, to improve the healing of the venous leg ulcers, and they recommend to reduce the pain too. If we remember, the patient with a venous leg ulcer has a lot of pain, is a lot of discomfort, and they have a lot of edema. Sometimes they have a swelling, and it's sometimes they are infected. So part of the treatment, of the complete treatment of the venous leg ulcer, is, of course, the compression stocking. So the 8th recommendation is the prevention of the progression of venous of chronic venous disease. This is well recommended. However, the evidence of using in treating established ulcers is less clear. Since 2008 consensus document for especially designed ulcers kits have no development. They consist of a 2-layer stacking system for uniform graduated compression and ease of application. This is very important. There's only 2 layers. There are some of them that have 4 layers. So we have to choose which one is the best for each patient. So for a talk, is sometimes difficult to show how to apply this kind of compression. So the thing is that you have to know that it's a beneficial effect for a venous leg ulcer healings. And it has been developed in several trials. But we have to know when we have to apply it and when we cannot apply it. So these are some contraindications about the compression stocking, the medical compression stocking, with patients with severe congestive cardiac failure, as the risk that they may develop systemic fluid overload from moderate edemas without can be achieved using light, no moderate, no high compression. It's light compression. And we can use light compression and the post-reconstructive edema after a successful bypass surgery. Sometimes this kind of contraindications, we have to see each patient because each patient is different. So we have to know when we can put a medical compression stocking light, medium, or high. So in patients with clinical limb ischemia, we cannot put it. In advanced peripheral neuropathy, we cannot put it. in patients who are older and they have like paper skin and they have another kind of troubles, we cannot put. And in patients with dermatitis and allergic reactions to the fabric, of course, we cannot put. That's why they put, first of all, we can put something with cotton, that is a sock with cotton, so we can reduce these allergic reactions. And for unusual leg sizes, shapes, or deformities, or stand-on of the shell stocking is unlikely to fit the patient. In these cases, the medical compression stocking should be customized by individuals. Like everybody knows, we are different. So we are going to talk a little bit about the compression fit standard calf foot. I guess this is a very good system for that applies. We have foot and we have calf, and this is calf and foot. So we can choose what we need, where we need the compressions. And I'm going to show you a YouTube video that it's very quick, but if you need to know how to apply it, it's the best going to with us to the AVC, and I can show you how to do it and how you can choose the best compression stacking for your patient. Like I said, it's kind of difficult in a few minutes to show you, so that's why I have to show you by person. This is just a video that we have from YouTube that it's very easy. It's 1 minute only, but you can have a good idea of how you can show your patient how to wear this compression stocking.
The Compreflex Complete is a versatile wrap that is indicated for wound care, including venous stasis ulcers, chronic venous insufficiency, stage 1 or 2 lymphedema, and post-surgical edema. It is made from a medical-grade laminated foam material, which is designed for better moisture wicking and air transfer. The garment can be set from 20 to 50 millimeters mercury compression. The garment includes medical-grade hook and loop for a long-lasting secure fit. The garment also features a curved spine for a better fit, along with a stretch panel for easy donning. The complete liners include a padded foot and ankle area with 10 to 15 mmHg compression that is gradient from the ankle to the top of the liner. The garment includes one Compreflex wrap, a pair of complete liners, and a set of AccuTap devices. Make sure your skin is clean and dry. Begin by donning one of the supplied liners. It may be easier for you to fold the liner in half as shown, or simply pull the liner on. With the stretch panel facing forward, slide your leg into the wrap. Pull the garment up the calf until it is roughly 5 centimeters or 2 fingers width from your knee crease. Close the straps without applying any tension, making sure that they are flat without gaps. Place one AccuTab device per strap as shown here, making sure that the size and AccuTab print are facing the strap. Apply each strap to the desired compression level.
So this is an invitation, so you can know how to do it. So for the video, you can see that it's very easy to use it, and we have to learn how to put it and how to take it out, because it has a way to take it out. And of course, After all, we have not only comprefit calf and foot, we have compreflex, and we have only from the calf, and we have the boot. So if you want to learn everything of this, you have to go with us to the AVC and take how can I say it? I forget the word in English. Forgot it.
Go in Spanish.
No.
Nikos can translate.
Oh, yes,
Nikos,
Rebecca, please help me. ¿Cómo puedo decir que vayan al curso, a tomar el curso para que aprendan a ponerlas?
To go to the workshop, to learn all these things.
To the workshop, yeah.
Absolutely.
I forgot the name
Absolutely,
of
they're great.
Yeah, thank you very much. Yeah, thank you. And besides that, this garment strap system gives it all the high range of adjustability, creating an accurate custom fit. This is very important. This is almost one of the unique that we have this adjustable, and it's very easy for the patients when they know how to put it. So my conclusion is that the very important, the venous leg ulcers are one of the most important complications of the chronic venous disease, and it has a very great impact of the quality of life of the patients. So we have to know how to apply appropriately. So you can use it every time you want it. And there have some techniques to use it. So if you want to learn it, come to the workshop. Thank you.
Perfect. Yeah, thank you so much, Rebecca.
Thank you, Rebecca.
I totally agree. I think it's a very interesting topic as well, but it's a topic that also needs hands-on and to take some products into the hands, as well as all the other topics as well. I think we already have a great vibe here, and really engage people. And imagine how this will be when all the people meet on site physically together. So are there any questions to the last presentations or the presentation before? Comments or questions from the panelists?
A quick comment will be, I think the presentations are really good, is what we need now, both for the sclerotherapy and compression and all of the exact techniques, is to find what's the proper dose response, I would say, and tailor it to everybody's need. For example, a person with like mild swelling or edema that it never goes away, or people with an ulcer, etc. And also find out what is the place when we're using other techniques together, superficial or deep. But I think it's evolving. I'm glad. I think the compression is improving a lot the last few years. Technology is getting better. Thing is now to find ways to optimize it.
Absolutely. I think that's a very valid point. You know, in Switzerland, we have this slogan, one for all and all for one. And I think especially in the ulcer treatment, this kind of slogan, I think it's also quite appealing. Yeah. And I think we will be able to learn a lot in having different industries, different perspectives on ulcer treatment within one workshop. So, again, please register. I hope there's more people registering. Also, there's just a limited amount of places as well. So that a little bit on the promotional side. On the medical side, are there any open questions, topics that need to be discussed today? If not, of course, we're very happy to discussing all of them in Maastricht. Yeah, there will be a lot of more time. Yeah, and also some, let's say, bilateral meetings in person. Yeah, so I think that's also the charm of Maastricht, to be able to ask during a lunch break about opinions. And
well, maybe Dirk, I can again just tell something about the EVC Congress, as Professor Tuanchi Suat already mentioned. We will have all days scientific sessions. We will have also one big compression session. This is Tuesday, and then Tuesday at 12:30 we will have a scientific session of the future of venous pathologies. the aesthetic phlebology, the stenting, treating DVT, compression, which is a very nice session. But then after it, on Sunday and Monday, we will have focused workshops with hands-on, in which Rebecca, Joanna, Maki, Sua, Tobias, all of the KOLs are involved. And I am, of course, very sad that Professor Lapropoulos Nikos is not there, but I am sure next year he will be there with us. So in Maastricht. Again, I would appreciate and would ask you to go to the homepage, use the app. The app is now online. You can use it easily. And if you are registered, you can use all the workshops for free.